You get the call. A 58-year-old male, dizzy spell. You walk in, he's sitting in his favorite chair, looking totally fine. He says, I stood up too fast, felt the room go gray and fuzzy, so I sat back down. I never actually passed out, though. This is a classic presyncope call. It's also called near-syncope. He almost fainted. Every instinct, every pressure from an overloaded system is screaming at you to chill out. This feels routine. Near-syncope has to be better than syncope, right? But what if that almost faint was the only warning shot for a massive pulmonary embolism or a life-ending arrhythmia? I'm Angry Bill, and this is Prehospital Wisdom. We understand that medicine is medicine, whether you're a nurse, EMT, paramedic, or physician. But pre-hospital folks have skills and knowledge that help them do their specific jobs. Come help me raise the bar. Back to my rant. The line between presyncope, almost fainting, and syncope, fully fainting, is razor thin, and the underlying causes are identical. Thinking that lacking in unequivocal unconscious period equals lacking in emergency is one of the most dangerous traps in medicine. Today, we're proving why you must treat that near miss with the exact same suspicion as a full-blown syncopal episode. Let's be real. It's 2 a.m., it's your 6th call, it's the 100th near syncope you've seen, and the patient is apologizing for bothering you. Your brain wants to file this under no big deal. We see a patient who looks fine, so we assume they are fine. It's a setup for failure. Pay attention here. The data is crystal clear. Near syncope carries the same risk as syncope. A just published 2025 study led by Edward Su found that patients with presyncope and syncope had similar rates of serious cardiac outcomes within 30 days. It was 5.2% versus 4.7%. The kicker? Physicians consistently underestimated the risk for the presyncope patients and were less likely to admit them. Another study found that in older adults, there was no statistical difference in the rate of death or serious outcomes at 30 days for those that almost fainted versus those that actually did. When it comes to a pulmonary embolism, one study from the Italian PE registry found that PE patients presenting with presyncope had a higher 30-day mortality rate than those who presented with full syncope. The perception that it's a lesser event, the perception is that it's a lesser event, but the reality is that it carries an equal and sometimes even greater risk. So why are the risks the same? It all comes down to one thing, a temporary drop in blood flow to the brain. Think of the brain like a light bulb. Syncope is a full blackout. The power is cut, the lights go out, and the patient loses consciousness. Presyncope is more like a brownout. The lights flicker and dim, the voltage drops, but it doesn't go out completely. The patient gets dizzy, their vision tunnels, but they hang on to consciousness. The critical point is that the problem at the power station is the same, whether it causes a flicker or a total outage. The underlying cause hasn't changed. Ignoring a brownout is like ignoring an engine that's sputtering violently just because it hasn't stalled yet. It's a dire warning. So what are these power station failures we're hunting for? First, cardiac causes. This is public enemy number one. It's arrhythmias. A sudden heart block or a quick burst of VTAC can tank cardiac output. By the time you arrive, the rhythm might be back to normal, and that moment of near syncope was your only clue. The other one is structural issues. Things like aortic stenosis or hypertrophic cardiomyopathy mean the heart can't pump enough blood when it's stressed, like during exercise. That story of I got dizzy climbing the stairs is a huge red flag. And I get it, like we don't always picture exercise-related syncope as a big deal, but it's actually a huge deal. I've been doing interval training and felt like passing out. It's not what we're talking about here though, right? So exercise-related syncope is a big red flag. The second main part is vascular catastrophes. PE, a massive PE can cause a sudden drop in cardiac output and brain perfusion, leading to presyncope or syncope. In patients with a PE, syncope is associated with a higher prevalence of hemodynamic instability and right ventricular dysfunction. It's a terrifying diagnosis where presyncope may be the only warning. Another one is aortic dissection or ruptured aneurysm. While less common, the internal bleeding from these events can absolutely start as just a dizzy spell. And don't forget the easy stuff. A TIA or a stroke can cause these symptoms, and always check a blood sugar. Let's get back to our guy in the recliner. We do the work required of us. We dive into his history. He confirms that he was standing up, but he also mentions feeling a little short of breath lately. That's a flag. His vitals are stable. I no longer check orthostatic vitals. They're a waste of time, but you do you. If you check them, they're not positive, of course. Now, for the most critical step, the 12-lead EKG. This is non-negotiable for any patient with near syncope. At first glance, it looks, all right. There's a normal rate, no obvious STEMI, but we look closer. I see a subtle, incomplete right bundle branch block with some T-wave inversions in V1 through V3. It's also got right axis. In a 58-year-old with new presyncope and shortness of breath, this pattern screams right heart strain. And the number one acute cause of right heart strain? A pulmonary embolism. Our whole view flips. This isn't a dizzy spell, it's a potential life threat. It is definitely a reason to transport the patient rather than letting him go back to bed. The CT scan at the hospital confirms a large bilateral PE. That brownout was the only thing standing between him and sudden cardiac death. Our refusal to dismiss it saved his life. So what's the bottom line? Number one, respect the brownout. Burn this into your brain. Presyncope has the same deadly causes and similar short-term risks as syncope. There's no such thing as just near syncope. Number two, the 12 lead's non-negotiable. Every adult with unexplained presyncope gets a 12 lead, period. Hunt for the subtle cues, new blocks, intervals, and inversions. I'll put a video about the 7 EKG findings to seek out in syncope patients soon. Keep an eye out for it. Number three, history is everything. The story surrounding the event is your roadmap. Ask about position, exertion, any other symptoms like shortness of breath or palpitations. What's the most subtle clue you've ever found on a presyncope call that pointed to something serious? Share your story in the comments below. Like and subscribe if you haven't already done that. You may as well, you've watched this far. Remember, the difference between near syncope and syncope isn't the diagnosis. It's just a few seconds of consciousness. Don't let your bias be the reason a catastrophe is missed. I'm Angry Bill for Prehospital Wisdom, and until next time, stay safe.